Hello to everyone. My name is Paolo Ghia. I'm Professor of Medical Oncology at Università Vita Salute San Raffaele in Milano, Italy, where I am directing the CLL program. So today I am here to discuss what has been published on the topic of chronic lymphocytic leukemia in the past years, and I will try to review the most relevant and interesting data that came out. In general, the data that I'm going to present are somehow the confirmation of data that we already knew, and therefore we are going to talk about the longer follow-ups of key seminal studies that has really proven the efficacy and the tolerability of many new drugs in chronic lymphocytic leukemia, and in particular on the BTK inhibitors and the Bcl-2 inhibitors, alone or in combination. The first study that we are going to discuss is actually a very interesting study, a very unique study, the phase 3 CLL-12 study that was run by the German CLL study group, though it was an international study. And this is a one-of-a-kind study because it was directed in enrolled patients who did not need treatment. And in particular, patients who were at high risk of progression, and they were randomized to either ibrutinib, or the BTK inhibitor, first generation BTK inhibitor, or placebo. So just the typical active surveillance that we would do in our patient. And probably to no surprise, we already saw the 5 years follow-up, and then now we have seen the 10 years follow-up, and with the 10 years overall survival, where we don't see any difference between ibrutinib and placebo. Of course, in a preemptive study, the endpoint cannot be progression-free survival, because in that case, of course, treating ibrutinib, the progression, the second progression, let's say, is definitely longer than with placebo. But the key endpoint has to be overall survival in such type of studies. And here, as you can see, the numbers are very, very similar between ibrutinib and placebo. There was a third cohort of patients who were not considered at high risk, and therefore they were followed in watch and wait or active surveillance. And you can see that they even had a higher percentage of patients who were still alive after 10 years. And this is somehow expected because those patients definitely had a very low risk of progression and need of therapy. Another study that also has been interesting in the past year was a pooled analysis of 5 different clinical trials where the second generation BTK inhibitor, acalabrutinib, had been tested. And this is a study presented by Matt Davids. And the meaning here is indeed that by combining hundreds of patients treated with acalabrutinib, we do confirm the efficacy of this type of treatment, and in particular, the plots that you are seeing are in treatment-naive patients, where we do see that the treatment with acalabrutinib alone or acalabrutinib in combination with obinutuzumab or in other combination are very similar in terms of response, in particular, or long-term outcome for all categories of high-risk patients, so those with deletion 17p and or p53 mutation, those with unmutated immunoglobulin genes, and those also with complex karyotype, though the complex karyotype here, it is still defined with the old definition of 3 or more aberrations, while instead we know that in CLL, the threshold of 5 or more aberrations is what can be meaningful in patients with CLL. The interesting point is to compare the different percentage of patients who did not progress yet after 4 years. And as you can see, as expected, patients with deletion 17p and p53 mutations have a slightly shorter progression-free survival compared to patients with unmutated immunoglobulin genes, and definitely compared to patients with complex karyotype, because those include definitely patients at low risk of progression. So we know that now the life expectancy and the outcome of patients with deletion 17p and or p53 mutation is definitely much improved compared to the era of immunochemotherapy, but still probably they have a little disadvantage compared to the remaining of the patient. In the study, they also pooled patients who were treated in the relapsed refractory setting. And as you can see, and as you may expect, the progression-free survival, the percentage of patients free of progression at 3 years, so now it's shorter follow-up, are definitely less, as we know and as we expect. And again, there is somehow a gradient between patients with unmutated immunoglobulin genes, those with a complex karyotype, and those with p53 abnormalities. And in addition, if you look at the patient in the relapsed refractory setting, but also in frontline, and you stratify the patient based on the line of treatment, then as we already seen in the past for ibrutinib, the first generation BTK inhibitor, we do see that the earlier line in which the drug is used, the better progression-free survival we obtain. So with roughly 10% less patients who are progression-free in second line, and even another 10 or more in third line. As I mentioned earlier, patient with deletion 17p remains a patient of particular concern. So you may see that here, again, when we stratify them by line of therapy, we do see that if we wait too long, so we are in 2 or more line of therapy, then the progression-free survival becomes very, very low. What is reassuring if the patient treated in frontline after 3 years, still almost 90%, 86% of them, despite having deletion 17p, they are still progression-free, which is again long-term results that are reassuring on the efficacy even in this high-risk population. So another important question that we always ask if how the different novel drugs are tolerated in different subgroups of patients stratified by age. So we know that in the era of immunochemotherapy, we had really to use different therapies based on the age and the fitness of the patient, because the tolerability of the treatment was very different, dramatically different between age groups, and therefore we had to select different treatments. Is it true? Is it the same in the era of novel therapies? The general feeling is that it's not, and this is a study that is indeed addressing this question by analyzing the patient who are older than 80 years of age. So really the elderly patient, where probably one line of treatment should be sufficient given their life expectancy. And this is the so-called phase 2 CLL frail study, where acalabrutinib, again, second generation BTK inhibitor, was used in patients very old or also frailed. And as you can see here, the overall response is exactly what you would see in any other patient with chronic lymphocytic leukemia. And in particular, you do see that the frailty score of the patient increases with the response of treatment. So suggesting the idea that the frailty of the patient in many cases is really associated to the disease rather than the age per se of the patient. So now we are starting a review of long-term follow-up of a number of key seminal studies, the first one being a phase 3 Sequoia study. Dr. Shadman presented at ASH the 5-year follow-up of so-called cohort 1. Sequoia study is a somehow complicated study where there were 3 different cohorts, 4 different arms. Here we are looking at the cohort of patients without deletion 17p, and who were randomized to either zanubrutinib, continuous treatment, second generation BTK inhibitor, or the traditional standard therapy for elderly fit patient, bendamustine plus rituximab. And as you can see here, this is the progression-free survival at 5 years. It's almost plateauing, meaning that it's 76, almost 76% compared to 80% that we had 6 months earlier, and as compared to bendamustine, that was already shown at earlier time points that it is overwhelmingly superior compared to bendamustine plus rituximab. But the nice data and the nice evidence that we are here reported here is that indeed we have a very high progression-free survival after 5 years, and that is decreasing very slowly with time. This is again what is now traditionally done in every study, is to stratify patients based on the immunoglobulin gene status. And here you do see a couple of things. The Sequoia study has been a key study because it really proved that patients with unmutated immunoglobulin genes, when treated with bendamustine plus rituximab, they have a much worse progression-free survival compared to zanubrutinib, to the novel therapies. And the advantage here is for both mutated and unmutated patients. But as you can see here, by comparison of the lines, is that though the mutated patients have a high advantage compared to bendamustine when treated with zanubrutinib, the unmutated patients have a dramatically higher advantage, really suggesting that, as we already knew, the unmutated immunoglobulin gene status was predictive of a poor response to immunochemotherapy. So in general, the Sequoia study, phase 3, the cohort 1, has really proved and confirmed that the PFS benefit using zanubrutinib, second-generation BTK inhibitor, is very relevant for patients compared to patients treated with bendamustine plus rituximab, and that in particular, the great advantage is for patients with unmutated immunoglobulin genes. From a safety standpoint, again, the 5 years follow-up did not show any surprise. We know already well that it's well-tolerated the drug and with low rates of atrial fibrillation. Another long-term, or probably not so long, but definitely the final analysis of a key study is the Alpine trial. So Jennifer Brown presented the final analysis, and the Alpine trial is a key study because compared head-to-head the second-generation BTK inhibitor zanubrutinib to the first-generation BTK inhibitor ibrutinib. And we already knew that zanubrutinib was superior to ibrutinib in terms of overall response, in terms of progression-free survival, in terms of safety, in particular in terms of frequency of atrial fibrillation. And here, this is confirmed at 3 years. It's definitely not very long follow-up, but is consistent and reproducible compared to the previous follow-ups at 18 months or after 1 year. So you can see the PFS where there is a difference of almost 10 points in terms of progression-free survival, and that is larger when we look at patients with deletion 17p and p53 mutation. In terms of overall survival, as we may expect, and luckily for all patients, there is no statistically significant difference, though numerically speaking, there are less deaths when using zanubrutinib compared to ibrutinib. And in terms of safety, as I mentioned, you can see the zanubrutinib in red and ibrutinib in blue. There is a dramatic advantage in terms of atrial fibrillation, while instead other adverse events of clinical interest like hypertension or bleeding remain very similar. What is also interesting, there were some initial hints that zanubrutinib could be associated with an increased risk of neutropenia, but as you can see here, the values and the frequency is very similar between ibrutinib and zanubrutinib. As I mentioned when I spoke about adverse events of clinical interest, those are the cardiovascular adverse events. And we already learned since the first introduction of ibrutinib that indeed the heart and the cardiovascular system in general is somehow a target also for the drug, so that there are what we call now adverse events of clinical interest, and we should always keep an eye before treating the patient with any BTK inhibitors. And those are in particular risk of atrial fibrillation, risk of bleeding, and in particular minor bleeding, but also the major risk is for major bleeding. Fortunately, they are very rare with all BTKIs, around probably 1%, and most of them resolve with no sequelae. And the other adverse event of clinical interest is hypertension, the increase of hypertension or less control with an established treatment. And now it became also evident that the heart failure can be indeed induced and associated with the use of BTK inhibitors. Ventricular arrhythmias remain luckily a very, very rare event that has been shown earlier ibrutinib, and still remains to be explored and definitely proven or not in the case of other BTK inhibitors. And so in general, this is a work by Dr. Kozarak that is trying to define the cardiovascular risk, so that in order to better stratify the patient when we decide to use a BTK inhibitor. What we are looking at is more or less evaluation of cardiovascular risk that is a general risk, the risk of thrombotic disease, the risk of bleeding events, it can be based also on the platelet counts. Of course, it is advisable to run an EKG before starting the therapy, like maybe in some particular cases a Holter monitoring. Definitely we have to learn and remember to measure the blood pressure in our patients. So at the end of the day, we cannot really exclude anyone from the treatment of BTKI. So the evaluation of cardiovascular risk should be done in particular to address all the ongoing issues that are unknown. So if there is an uncontrolled blood pressure, if there is an ongoing minor cardiovascular failure, if there is already a previous bleeding risk because the patient is taking anticoagulant or anything, so that we can really maximize and optimize the therapy so that the patient can start the therapy with BTK inhibitors in the best condition possible. There is no particular subgroup of patients that should be excluded from the treatment with BTKI, with the only exception of patients who are on double anti-aggregation therapy, like typically after a stent. But we know that that period is becoming shorter and shorter thanks to the improvement and the research in cardiology. And so that is typically we can wait until the patient ends the period of anticoagulation, double anticoagulation, anti-aggregation, and therefore we can start the BTK inhibitor if we believe that that's the best therapy for our patients. So here there is again the algorithm that you can check in details if you want, but it's a general. One should really be attentive on these different aspects of cardiovascular disease in order to optimize and improve the therapy to control any particular ongoing cardiovascular disease, so that we are not worsening it with the BTK inhibitor therapy. Another seminal study for which we have seen now during the past year is the CLL14 study, phase 3, 6 years follow-up. This is again a study from the German CLL study group, though it was again an international study. And it is a seminal work that showed that the combination of venetoclax plus obinutuzumab, venetoclax given for 12 months, obinutuzumab given in the first 6 months, was superior to chlorambucil plus obinutuzumab in the elderly comorbid patients. And so we know that venetoclax plus obinutuzumab was better than chlorambucil plus obinutuzumab in terms of progression-free survival. This is, of course, confirmed also after 6 years. The impressive result is that even after 6 years, more than 50% did not yet progress. And this is particularly astonishing because the patient received only 12 months, 1 year of treatment. As we already learned in the past, and that is confirmed also with the 6 year follow-up, is that certain genetic features may have an impact on the long-term response. So if we look at patients with p53 deletion and or mutation, then you do see the blue curve, the solid blue curve in the middle. These patients have a shorter progression-free survival compared to patients without these aberrations, and therefore the median progression-free survival has been reached already a long time ago, 51.9 months, so roughly 4 years, which means 1 year of treatment, 3 years after treatment, half of the patients are already progressing. For the immunoglobulin gene status, similar though less dramatic pictures where patients with unmutated immunoglobulin genes, they progress earlier than patients with mutated immunoglobulin genes, but that the 50% threshold occurs, so 50% of the patient will progress after 64.8 months, so more than 5 years. So it's 1 year of treatment and more than 4 years and a half of progression-free survival. The bad news, because we all expect it, is that the mutated cases, though they respond very well and with the median progression-free survival is not being reached, we really hope to see a plateau, like we were seeing with the fludarabine, cyclophosphamide, and rituximab. At the moment, is not yet evident. So, of course, we see the plateau with the FCR after 10 years of follow-up. So we are hopeful that in the future, we will see at least a proportion of patients that will be plateauing in terms of progression-free survival. This is overall survival, and again, there is an advantage for venetoclax plus obinutuzumab compared to chlorambucil plus obinutuzumab. And again, for patients with P53, there is no doubt patients with P53 aberration should not be treated with any chemoimmunotherapy. And again, you can see that patients with unmutated immunoglobulin genes are those who have the highest advantage compared to the immunochemotherapy. Patients with mutated immunoglobulin genes, probably they have a lower advantage that is becoming evident only after a long follow-up. Of course, when venetoclax is involved in the treatment of patients, the important data is the achievement of measurable residual disease, so the previously called minimal residual disease, MRD. Two pieces of information. The first one is that all patients after 6 years lost the status of undetectable MRD. So we were not able with that only 12 months of treatment to maintain the persistence of undetectable MRD in any patient. And of course, as we know, there is an advantage in achieving undetectable MRD compared to those who do not achieve undetectable MRD. But the important information is that compared to chlorambucil plus obinutuzumab, reaching 10 to the minus 4, so one cell, less than one cell in 10,000, 10 to the minus 5, one cell in 100,000, 10 to the minus 6, one cell in 1 million, doesn't make a big difference after 6 years, while instead it makes a huge difference when you use chemoimmunotherapy already after a couple of years of treatment. So this is the good news, and this is something that we are going to be learning with the next follow-up to see really if and when there will be a difference in the level of undetectable MRD in terms of progression-free survival. Another study that I want to talk about is a very interesting study because it's somehow we all dream of doing something like that, an adaptive duration of treatment in our patients. This is a phase 2 study by Dr. Thompson, again using venetoclax plus obinutuzumab. After 6 years, we know that we don't maintain undetectable MRD in patients. And the patient progressively progress, so we didn't achieve any plateau. So the idea would be, why don't we personalize the duration of the treatment based on the MRD? And so patients were analyzed for the level of undetectable MRD after 7 months. Those who were undetectable continued until 9 months and they stopped. Those who were detectable at 7 months continued until 12 and then they stopped. Those who were positive at month 12, they continued for an extra year and they all stopped regardless the MRD status. Again, with the idea that still we don't want to do any more continuous treatment. We want to have anyhow a fixed duration treatment so that patient can experience a long drug holiday period, in particular without potential adverse events, financial costs, and so on and so forth. And these are the results where we do see that we have, of course, a follow-up is still short, 12 and 24 months, but it's very promising. I mean, we are well above 90%, of course, in terms of progression-free survival, much higher in terms of overall survival. So it will be interesting to see in the future how this curve will be maintained. Another important study for which we have seen a longer follow-up is the Ghia CLL13 phase 3 study. A rather complicated study again by the German CLL study group. And this was a study frontline again, in which a different combination of venetoclax was compared to classic chemoimmunotherapy, SCR, fludarabine, cyclophosphamide, and rituximab for young fit patients, or BR for bendamustine rituximab for elderly fit patients. And it was compared to venetoclax plus rituximab, that is the traditional treatment in relapsed refractory, venetoclax plus obinutuzumab, which was already the standard of therapy in frontline, and venetoclax plus obinutuzumab plus ibrutinib, so a triplet combination, including also the BTK inhibitor. We already knew that the best treatment in terms of undetectable MRD and progression-free survival were the triplet, venetoclax, obinutuzumab, ibrutinib, and venetoclax plus obinutuzumab, which were superior to even venetoclax plus cetuximab, and definitely to chemoimmunotherapy. The interesting point was that at the earlier time points, we didn't see any difference between the triplet and venetoclax plus obinutuzumab. Now we start seeing this difference, though again, not visible at 48, and we will see if we will longer follow-up, it might become really statistically significant. In this case, again, I show you the result for unmutated patient and patients with mutated immunoglobulin genes. Again, patients with mutated immunoglobulin genes have always a better response, a better outcome, but also in the mutated patient, we do see a difference between the triplet and venetoclax plus obinutuzumab compared to the other treatment. The advantage is always maximal in patients with unmutated immunoglobulin genes, where probably the triplet combination might show more benefit, and probably this can be also discussed in the light of the results by the Amplify, where acalabrutinib was combined with venetoclax and obinutuzumab, showing similar trend for patients with unmutated immunoglobulin genes. But the Ghia, the CLL13 study, also showed us already in the past, and that's confirmed also 4 years follow-up, that there is a price that we have to pay for the triplet, which is in terms of safety. So infections, you can see number of infections in purple are in the range of those that we have with patient treated with chemoimmunotherapy, and that is also true when we look at grade 3 or more infections. So it might be that we have a more sustained response, but it's also true that we are exposing the patient to higher risk of infection. That's again, it will be nice to talk about when looking at the data from the Amplify study, and it's something that we have to understand well. So in order to better understand who is our candidate, potential candidate for the use of triplet. And again, also for cardiac disorder, the triplet has much higher cardiac events compared to any other treatment with venetoclax. Of course, we are using a BTKI, so this is always something that we have to keep in mind. And with that, I conclude with a summary of the Ghia study that is, again, we are all looking forward for more additional follow-up, longer follow-up, in order to understand better the role and the placement for the triplet venetoclax, obinutuzumab, and ibrutinib. We conclude with the Cristallo study. The Cristallo study is a phase 3 trial where the combination of venetoclax obinutuzumab again was compared to chemoimmunotherapy, but for young fit patient or elderly fit patient, so FCR again or BR again. So it's including the patient who were not enrolled in the CLL14, where venetoclax obinutuzumab was compared to chlorambucil plus obinutuzumab. The scheme is very easy. 1 year of treatment with venetoclax given for 12 months, obinutuzumab for 6 months, and FCR-BR the usual 6 months of treatment. And here you can see that the combination is venetoclax plus obinutuzumab is much more potent in obtaining MRD that we already knew. This was the primary endpoint, undetectable MRD in the peripheral blood, more than 80% of the patient, as assessed by next-generation sequencing. The second endpoint, which is the PFS, is not yet mature. There is no statistically significant difference, but you can see that at numerical level, there are less progression with venetoclax plus obinutuzumab. And therefore, we hope to see longer follow-up, but also that at least start confirming that also in the young or younger patient, fitter patient, Venobi is a an option that is very valuable, is beneficial for our patient. At the moment, definitely in terms of undetectable MRD, where we know from the CLL14 that undetectable MRD tend to correlate and associate with the PFS. And in particular, we know that in the future, undetectable MRD rate will probably become, or should become, somehow an early time point, an intermediate time point to assess the efficacy of the novel treatments. The last but not least, a study, a Venice study, phase 3B with single arm, where venetoclax monotherapy was studied, but in relapsed refractory patient with CLL. Arnon Carter was the principal investigator. Venetoclax monotherapy has never been tested really seriously, let's say, in the relapsed refractory setting, because it has been almost immediately associated with rituximab. So this is the treatment really to show that even venetoclax alone is very potent, and in particular when looking at the data from the CLL13 Ghia, where obinutuzumab is so much more potent compared to rituximab when associated with venetoclax, we really wonder what venetoclax is adding to the venetoclax monotherapy if taken continuously. And you can see here that the response is very promising, meaning that with 1/3 of patients achieving complete response, even if patients were exposed earlier to BTK inhibitors, or they were naive to BTK or even PI3 kinase delta inhibitors. These are the curves. What we learned from this study, unfortunately, is that the patient who has been exposed to BCR inhibitor, let's call it kinase inhibitor, which is probably the best term, there is, if you use venetoclax, you have 24 months of PFS as a median value. So we know, and that's an awareness that is becoming clear to everyone, is that patients failing continuous kinase inhibitor, they are really difficult to treat, and therefore when we use venetoclax, even in combination treatment, we always achieve a couple of years of progression-free survival. Luckily now we will have probably very soon in the United States, they already have. In Europe, we will have probably soon the BTK inhibitors of 3rd generation, which in particular pirtobrutinib, who hopefully will be approved soon. So in general, venetoclax monotherapy demonstrated, as we already knew, but at least in a prospective study, that can achieve deep and durable responses, regardless the use of previous kinase inhibitors, and there was no flag in terms of safety issues.